This is a case of foot pain. I'm Jerry Hesch with the Hesch Institute in Henderson, Nevada, very close to Las Vegas, where we do consultation and treatment for complex pain clients and teach seminars and distance learning for hands-on clinicians. And our client is a 29-year-old female who had severe pronation in both feet and had a surgery on the left foot, which had greater instability. You can see the surgical scar here, and the purpose was to rebuild the arch, and also an Achilles tendon repair. They lengthened your Achilles tendon. Okay. And can you describe what your symptoms are in general?
My feet go numb a lot. I don't have, I have poor circulation. My toes now curl under. I can't really move them. I can't straighten them, lift them, nothing except for my big toes. And my ankle feels very generally weak.
So you're talking left?
Left ankle,
okay.
Yes.
Alrighty. And you also have knee pain and hip pain?
Yes, my knees burn constantly. They snap, crackle, and pop constantly if I move up and down. Walking takes a lot of effort. My hips feel out of place and unaligned as well.
Now, when you say hips, do you mean your pelvis, or do you mean the actual hip joint, the ball and socket joint? Which one are you speaking of?
I'm not sure.
Can you point to them?
Sometimes, I don't know, just here, my hips.
Yeah, it's okay.
Sorry.
Yeah, no. On the skeleton, you can keep filming on her. On the skeletal model, you know, this is what we call hip here, the ball and socket joint, whereas this thing we call pelvis.
Okay.
Okay, so does that help?
Okay, yes.
So which one feels?
This.
The hip. You're pointing to the hip joint.
The hip joint.
Very helpful.
Yeah.
Okay, very good.
It's different, it comes and goes, but yeah.
Yeah, all right. So the problem with the feet are more constant.
Yes, constant, always.
Okay.
I've collapsed many a times just because my feet go numb.
So you're standing or walking and you're not aware of the ground.
Yeah.
Okay. So there could be several things intersecting with your presentation. There could be a much greater complexity, you know, to what's going on. I do find some interesting things that I would like to treat and see how they impact your presentation. Okay? On both feet, which is fascinating because your surgery again was on one foot.
Mm-hmm.
So what's fascinating is that you present with this weakness on both sides. You can't lift these toes up. You can do a little bit on the last toe, but pull your big toe up. Show me how strong you are. Okay? So hold it there so that's got very good strength. Okay? Now, straighten out these toes. They're curled. Straighten them out. Lift these toes up.
I can't.
So you can't. You hardly see the tendons engage. Try again. Okay? Can you push the toes down? Okay, so pull into my fingers. Pull down. So you can bend them, and now you see the tendon stretching when you pull them down, but you have weakness such that you can't lift them up. And that's on both sides, which is really odd. So we wonder if during the surgery, no intention, but if weight was put on both legs to stabilize them, or a cuff to strap you to the surgical table, and it just happened to be too tight for your body. That's one possibility. There's other possibilities. That is one possibility. Okay? There are some mechanical things that I think can be treated, and so the curiosity is to see if we treat those mechanical things, can we improve your function? And that's what our efforts will be. You do present with asymmetry of your leg length because your pelvis is uneven. Okay? You could have a small amount of scoliosis when you bend forward and I put a book under your left sit bone and get your pelvis even, but your spine still remains a little bit uneven. So you could have some scoliosis, but it's not severe. Okay, so that's a good thing. The ankle bones, you have, pretty good mobility throughout your feet, but your ankles are rigid. They only allow you to dorsiflex to neutral. So there is some stiffness in spite of your overall flexibility. And can you tell us what you do for a living?
Yoga.
Yeah.
And belly dance.
Yeah, yoga and belly dance. I mean, it's a paradox because you must struggle profoundly when you're doing either of those activities, right?
Yes.
So that's quite a challenge. Well, what I think is that there is some restrictions in your ankle joints that we could treat. Again, I can only bring your feet up to neutral. The fibulae on both sides is very much forward, but what's remarkable is the one on the left is even more forward down here. I know that we can't capture that quite with the camera. It's just not going to show from my perspective, but it is, having looked at lots of feet and ankle, this is very much forward. It doesn't matter how something looks, it matters how it functions. Okay, so the question is, even though it looks forward, can I create any movement through that joint? And the answer is no, I can't. Okay, on this side, can I create any movement through that lateral part of the ankle joint? The answer is no. Can I bring it forward? Yeah. Can you feel that little give? Mm-hmm. Can you feel that bounce? Mm-hmm. Okay, so when I come up to the very top of it, can I push it back towards the floor? No. If I come behind it, can I bring it forward? No. So I'll have to, it may be that up here that it is more posterior, and that could change forces in this area and could impact the deep and superficial common peroneal nerve. We don't know that. I do understand that after weight bearing for some time your numbness even gets more. I understand, you tell me that you have cold feet, and I feel cold feet, and I tested your sensation, and it seemed to be okay or just a little bit off, but afterwards there was like a delay, and then it felt a little more tingly after I had, so there's a hypersensitivity without a doubt. Okay, on each side I cannot spring your fibula up. I can't do that on this side, but the subtalar joint seems to have good mobility, and that might actually increase. If I can restore more ankle mobility, this mobility might actually increase, and that might serve you well. We'll find out. So we've established that you have weakness, and I did test your other muscles. You can do a bunch of heel raises, so your calf muscles aren't weak. Pull your toes up and your foot up towards you. You're very strong here. You're very strong here. But when I test the E version, when I test the peroneal group, which is actually now called fibularis group, you're quite weak. Hold it up and out there. So that's just so easy for me to break. Okay? And on this one, bring it up and out. And that's also so easy to break. That might improve. Okay? I know it causes you duress. Okay? But bear with me. We'll see if we can improve that.
Okay.
All right? And I know that your mechanics on this foot, of course, are different. And I know that there are some limits to what we can do. And you pointed out how the toe now looks more like a thumb and such. And yes, surgery will make some permanent changes that we can't alter. But I want to find out, what can we do with you? What is reasonable and appropriate? That's what we need to find out. You do stand with evidence for your leg length difference. As you sit here, the left leg looks longer. Now lay down, let's see what that does. And when you lay down, it looks longer on the left side. When you stand, you bend the left knee. So that fits. Okay? Your pelvis is very much uneven on both sides. And so much to the degree that I cannot induce motion through the joint on the left, and I cannot induce motion on the right. So some people would say, oh, well, that's just kind of a posture, or muscle is pulling it, making it uneven. In this example, and because you have more hip pain on this side, I think it's worthy of consideration. And the scoop is that I want to find out, can I impact that? Can I alter that to where it is beneficial to you? You lay and sit and stand with significant pelvic asymmetry. Well, a lot of people would say, well, who cares? But it changes your leg length. Not your true leg length, but you know what I'm saying. So that does matter, and this is a shock absorber, and you're not absorbing any shock, and you happen to earn your living as a yoga person and as a belly dancer, and you need shock absorption.
Yes.
Okay? So honestly, I cannot load this structure. It is so tight, which is so incongruent with your body type. Therefore, I think it is treatable, and therefore it is an anomaly. You're very flexible everywhere, and then you come to the pelvis, it's like a block of concrete. I did check the pubic structure. You've had 3 children. Any of them difficult too?
No.
Okay, so they were all right.
Yes.
Now, your left pubic bone is higher, and there is a distinct step down. Because there is a step down, I think that an x-ray would capture this, and I think it would show that there is in fact a downward shift on the right side. So it may be that we'll treat that and get the right side to go back up, which is, it does take at least 5 minutes. It's a very dense joint. So it's not something you do something quick and it moves. That's not the case. Let's have you lie on your stomach. And when you're on your stomach, I can't, go ahead and lay down and relax. I can't create any motion here. I can't create any motion here. I come over on the ilium near the top. I come down on the ischium and try to spring it. I come here and I try to spring vertically and there's nothing. It's just extremely rigid, and it doesn't go inferiorly either. And yet if we test the spine, you have good mobility there throughout your body, throughout the rest of your spine. Ribs spring very nicely. The force goes through them. You have excellent hip mobility in all directions. Now, I did screen your right hip in a little bit more detail, and you do have tightness in the right hip more so than on the left. This is the trochanter, and the back of this trochanter sits on the right, sits more posteriorly. Let's have you lie on your stomach, and I'll show that to you a different way.
Lie on my stomach.
On your back. Lie on your back, please. So in this position, I can take this left leg and I can rotate it medially and overpressure, and that feels normative. The right one, I roll it in until it gets to a stop point, and at that stop point, it's firm. There's a hard end feel, so it doesn't feel like it can go further. Whereas on the left, I take it to an end point, and I can easily impart a little more movement. Do you feel that?
Yeah.
Do you understand that?
Yeah.
So I would like to restore that motion as well. We'll be finished filming very shortly. Could you stand up so we could just film your body and how you stand? So this is your normative stance. I stopped you while you were walking, and this is the way you stopped.
Yeah.
Your left knee hyperextends relative to the other one, and you step back a little bit on the left. You're, maybe an inch, half an inch backwards. And you do that because the pelvis is asymmetrical, and you do that to sort of even things out. In this position, your pelvis becomes pretty symmetrical. Okay? But if you step forward with the left foot into my finger, good. And then if you don't hyperextend this knee, stay right there, you're good, that's good. Then you get asymmetrical up here. So this is an adaptation for this. Therefore, I'd like to work on this. Okay? Go ahead and sit facing away from me. And bend forward as far as you can. And you have more tone in the left paraspinals, and your pelvis is perceivably uneven in this position. If I put a book under here and I get the pelvis even, you still have more tone on the left paraspinal muscles. You might have a little scoliosis, or it's hyperdeveloped over a long period of time. But here's the plan. I'll go ahead and sit up and relax. What I'm going to do is see if I can enhance mobility in your ankle, and see if I can enhance mobility through the fibula at the bottom, which is the outside of the ankle, and at the top, called the superior tib fib joint. I'm going to work on improving internal rotation of your right hip, and I'm going to work on restoring mobility through the pelvis. It's like a block of concrete. And then I want to just see, what does that do for you? Okay, we don't know. I have some hopes and some optimism, and we'll find out what I can't do too. And that's what we want to know. We want to know what's doable and what isn't. So we'll stop filming here. I'll go to work and we'll come back and refilm.
Okay.
Okay? Thanks.